So if there's a more personal question you don't feel comfortable asking in front of the group, feel free to contact me afterwards. That's the one disadvantage with Zoom. If I was there in person, then we could have spoken afterwards. So question one, I get asked a lot. What's the difference between an optician, an optometrist, and ophthalmologist? So an optician is someone who is trained in filling prescription for eyeglasses. They help you determine what frames fit you the best, what looks the best. They adjust the frames. So when you get your prescription for your eyeglasses and you go to an optical shop like LensCrafters or Pearl Vision or VisionWorks, the people that are in the front part of the store that are helping you fit the glasses and fitting it to your eyes, they're the opticians. An optometrist is an OD, which is a doctor of optometry. So they've done 4 years of college, and then they did 4 years of optometry school after that. And they can perform eye exams. They can determine a lot of the problems you might have with your eyes, such as diabetes or glaucoma. They can prescribe glasses and contact lenses as well. In some states, they're allowed to prescribe eye drops. That really varies state to state. So in Maryland, they can prescribe certain eye drops, not all, and they can prescribe certain oral medications as well. Again, not all. Many times they have to still work with an ophthalmologist or a medical doctor to prescribe these. Again, that varies state to state, and this seems to change every year, every 2 years or so, what they're allowed to prescribe and what they're not allowed to prescribe. Optometrists cannot do any surgery. So when it comes to laser surgery or cataract surgery or removing a foreign body from the eye, things like that, they're not allowed to do that. Again, that varies by state. I'm talking mainly about for what it is in Maryland. So the optometrists, again, they're usually the ones that are working at the LensCrafters or retail stores, Costco, LensCrafters, Pearl Vision. Those are usually optometrists working there. An ophthalmologist, which is what I am, is either an MD, which is a doctor of medicine, or a DO, a doctor of osteopathy. And what ophthalmologists have done is they have done 4 years of college and then 4 years of medical school. And during medical school, you do a general training in everything. You do an internship after that in either medicine, internal medicine, or surgery. And then you do 3 years of ophthalmology residency after that. So after my medical school, I did an internship and I did 3 years of ophthalmology training. Many ophthalmologists, like myself, we did an additional fellowship. I did a fellowship in cornea and cataract surgery, but you can do a fellowship in retina, glaucoma, pediatrics. So there's different subspecialties within our field that you can do an extra fellowship in. Ophthalmologists can also prescribe glasses and contact lenses. Not all ophthalmologists do this. Many ophthalmologists will stick to more of doing the medical part of the exam. They diagnose and treat eye diseases. They can also perform surgery. So cataract surgery, retina surgery, glaucoma surgery is all performed by ophthalmologists. And most ophthalmologists are board certified by the American Board of Ophthalmology. If you want to know if your ophthalmologist is board certified, you can always go on the American Board of Ophthalmology website, type in their name, and it tells you whether or not they're board certified. But I'd say, majority of ophthalmologists are board certified by the American Board of Ophthalmology. While I was talking about ophthalmology versus optometry, one of the other big questions that comes up is about vision plan or versus medical insurance. Okay, so a vision plan. Many patients or many people you have your medical insurance and you have a separate vision plan through your insurance. All a vision plan covers is refractions, which is a prescription for glasses, the glasses themselves, and contact lenses. Okay, so if there's anything else, the vision plan doesn't cover that. The medical insurance will cover your medical issues. So if you have diabetes, if you have red eyes, you have itchy eyes, you go in for a medical reason, it's all through your medical insurance. Any surgical issues such as cataracts or retina surgery is also covered by your medical insurance. Many times we get patients calling our office and saying, oh, here's my vision plan. I have diabetes and I have eye pain. And we have to explain to them that that's actually through your medical insurance, not your vision plan. Many ophthalmologists don't even take vision plans. I actually don't take any vision plans in my office. Everything I see patients for is all through medical insurance. So the vision plans are usually the commercial retail places that take it, such as the My Eye Doctors and Vision Works and Lens Crafters. They take your vision plans. Now, if you show up at, I know there's a Vision Works in the Dobbin Center, not too close from you guys. I mean, not too far from you. If you show up there with a red eye, they're not going to see you through your vision plan because you have a medical reason to be seen. They'll have to do medical insurance, which they may or may not take. So it's a little bit of a fine line of how we have to treat this, but this is the way the insurance companies have made it. So we have to follow their lead on this. Besides that, then there's a lot of, there are some out-of-pocket procedures that are not covered by insurance at all, such as LASIK. Any refractive procedure like LASIK, insurance companies consider that to be a cosmetic procedure. So they don't, no insurance is going to pay for that. Cataract surgery is covered by insurance, but in the past 10 years, there's what we call premium cataract surgery. And I'm going to get into this a lot more in a few minutes. But that means that laser assisted cataract surgery, different various lenses we use, these are not covered by any insurance, whether it's Medicare or any commercial insurance. So they may cover the surgery part, but they won't cover the other premium products you might get, and that you have to pay out of pocket. So another question I get often asked is, what does 2020 mean? We all hear about 2020, and most of us don't know what it actually means. A person with 20/20 vision can see what an average individual can see on an eye chart when they're standing 20 feet away. So that's what we mean by 20/20. If the average person is standing 20 feet away and they can read that eye chart, read the letters on the eye chart, and you can also, then you're seeing 20/20. So the top number is the distance in feet from the chart. So, and then the bottom number is the distance at which a person with the average eyesight can read the same line. So for example, 20/30 means that from 20 feet away, you can read the same letters that most people can see from 30 feet away. Okay, so when we say 20/20, again, that's average vision. So 20/20, is 20/20 perfect? And 20/20 is actually not perfect vision. 20/20 is average vision. So there are a lot of people that are better than 20/20. A person can have 20/15 or even 20/10 vision. The goal of glasses or contact lenses is to bring your vision to 20/20. And we call this a best corrected visual acuity. And we care about what your vision is with the best correction. So I have patients who come in and say, oh, my vision's really blurry. But when they put their glasses on, they're 20/20. And that's all we really care about. And we say, you know what? You have to wear glasses, just like I'm wearing glasses. You have to wear glasses to see 20/20. Most of the time, and I think in my office and I think almost any eye doctor you go to, we're rarely going to get checked to see if you're 20/15 or 20/10. When I have my staff, when they have the person reach 20/20, they usually stop checking at that point, because to me, it doesn't really matter. It's not going to change my medical judgment whether they're 20/20 or 20/15. Although every once in a while I do get a patient who wants to show off, and we have to kind of go down the 20/15 line or 20/10 line and have them read it. But again, it's not going to change my judgment. So I tell my staff, I said, when you reach 20/20, you can stop checking it. So only 35% of adults actually have 20/20 vision without glasses, contact lenses, or having had eye surgery, cataract surgery usually. Wow. And even with correction, meaning glasses or contact lenses, only about 75% of adults have 20/20 vision. So it's not a big deal if you don't have 20/20 vision. Okay, so there's, again, we say 20/20 is average vision. There's going to be some people better than average and some people a bit less than average. Most states, including Maryland, you need to have 20/40 or better to have an unrestricted driver's license. And that's what most people care about, is I want to go get my driver's license. So as long as you are 20/40 or better, and that's with glasses or without glasses, you can have an unrestricted license. If you're 20/40 or better without glasses, then we can put on your form, your MVA form, saying that you don't need to wear any glasses for driving. If you need to wear glasses to get to 20/40 or better, then you have on the form that you need to wear glasses or contact lenses. So the patients who are 20/25, 20/30, even 20/40, they might say that, oh, I'm not quite 20/20, but they're perfectly fine. That's their vision. And yeah, they don't see quite as well as somebody who is 20/20, but they're perfectly fine to drive. they've gotten used to their vision, they're okay with that. Legally blind is if your best corrected vision is 2200 or less. So even with the best glasses we can give you, if your eye cannot see better than 2200, meaning that you're standing at 20 feet, what somebody else could see at 200 feet, that's when you're considered to be legally blind in the United States. Outside of the US, everything is measured in meters. If you read any sort of eye charts or you have friends in other countries, they might say, oh, my vision's 6 out of 6, which means 20 out of 20 when you convert into meters. The other reason, and I'm sure that those of you who've had your eyes checked, you kind of see the reason we do mirrors in the exam rooms. A lot of exam rooms will have mirrors, and you are looking at the mirror, and the eye chart might be behind you, is because it's too expensive. Because we're trying to measure your vision at 20 feet, and it's too expensive to have I would pay too much rent if I had all my rooms at 20 feet. So that's why a lot of offices will have mirrors. I have one mirror in my room. So actually, if you're in my office, I think I measured at one point, it's actually 19 feet 4 inches from where you sit and you look at the mirror and the screen behind you. So when I adjusted my monitors, my vision monitors, I typed in there 19 feet 4 inches. So they adjust the size to make it as if it's 20 feet away. And that's why when you go into an ophthalmologist or an optometrist office, you might see one mirror, there might be 2 mirrors. So it just depends on the size of the room, because they're trying to get it as close to 20 feet as possible.
Wow.
So another question is, what are the different parts of the eye? And I think really to understand a lot of the conditions of the eye, disease of the eye, it's important just to kind of know, the basic anatomy of the eye. So I'm going to start kind of in the front part of the eye and just kind of work my way backwards here towards the back of the eye. Okay, so I'm just going to move something here. So the surface of the eye is, and the inner surface of the eyelids are covered with a clear membrane. It's called a conjunctiva. So this is kind of the white of the eye. And in front of the white of the eye, there's a clear layer, and that's called the conjunctiva. So when somebody says they have conjunctivitis, that's actually inflammation of that outer layer of the eye. Also on the surface of the eye are the tear layers. And the tears lubricate the eyes. They're made up of 3 different layers: the mucus layer, the watery layer, and the oil layer. And the gland, the lacrimal gland, which sits kind of on the outer edge of your eyebrow, underneath the outer edge of your eyebrow, away from the nose, that's what produces a lot of the tears. Meibomian glands are in your eyelids, and that's what produces a lot of the oil. So it's a combination of the watery part of the tears from the lacrimal gland and the oil from the meibomian glands that helps create the tear layer. And we'll talk more about dry eyes and tear layers in a few minutes here. If we go further kind of backwards, the first thing you come across is the cornea, which is a clear layer over the colored part of the eye. If any of you who have worn contact lenses, the contact lens sits on top of the cornea. Behind the cornea is the colored part of the eye. That's the iris. And that's when we say, oh, I have blue colored eyes or I have brown eyes. That's the iris that gives us the color of the eyes. The iris is like a donut or a bagel. It has a hole in the middle of it. And that's what that hole is, the pupil. So when your pupils are big, that iris has changed its size. When you get your eyes dilated, what we're actually doing, if you've had an eye exam and you have your eyes dilated, we actually relax the muscles of the iris with the medication so that the iris, the pupil gets bigger so that we can see into the retina on the back of the eye. Behind the iris, behind the colored part of the eye, is the lens, which is a clear lens. Everyone, when you're born, you have a nice clear lens. As you get older, that gets cloudy, and that's what a cataract is. We'll talk about cataracts a lot more in a few minutes here. And then behind the lens, the back of the eye, is the retina, and that's sort of like the film of a camera. So all the images that we see get put onto the retina, and then our retina, which is all nerve tissue, processes it as if it's like the film of a camera and sends it to the optic nerve, which is a nerve that connects the eye to the brain. So these images are processed, sent through the nerve to the part of the brain where you allows your vision, and that's how we see things.
Wow, pretty cool.
So another question I get is, why is it harder to see things up close without glasses as I get older? And what this is, it's called presbyopia. And the literal translation from Greek for presbyopia means old eye. And this starts occurring after the age of 40. So around 43, 44 years old, you start not being able to see up close as well. You have to hold reading material a little bit further away, your cell phones further away, iPads a little bit further away. And this is all kind of part of the being in the 40s. So why does this happen? When you're young, and young meaning like up to the age of 40, your natural lens, remember we talked about that clear lens in your eye, it's soft and flexible. So it can change shape and allow you to focus at distance and at near. As you get older, around 43, 44 years old, that lens starts to become more rigid. It can't change shape quite as easily, so it's harder to see up close. And there's absolutely no way to stop this. Okay, I get that asked all the time. Hey, can you reverse this? And right now, as of right now, we have no way of stopping this. The only way it can be corrected is with glasses, and that's why as you get older, you have to start wearing reading glasses. You might have bifocals or progressive lenses in your glasses, and that's all because of this, to be able to see up close as well. You can also wear contact lenses or have surgery done to try to repair it. Okay, another question is about diabetes. A lot of patients, unfortunately, there's diabetes very rampant in this area, and they ask if diabetes can affect their eyes, and it certainly can. Diabetes, meaning you have high blood sugar levels, can cause damage to the blood vessels in the retina, which is the back of the eye. It can cause a lot of the blood vessels to swell and leak. They can close off. You can get ischemia, meaning lack of oxygen to certain parts of the eye. Abnormal blood vessels can also grow. Luckily, if your diabetes is under pretty good control, this is pretty rare that this would happen. What are some of the symptoms of having diabetes in the eyes? Really, initially, you have no symptoms at all. And that's why it's really important for somebody with diabetes to have their eyes checked with a dilated exam at least once a year. Initially, you might start getting some blurry vision as well. You might see some floaters, like black spots floating around in your vision. You might have some blank or dark areas in the field of vision as well. What we want to do is, if you do have diabetes, you definitely, of course, talk to your primary care doctor about controlling your blood sugar. The more well controlled your blood sugar is, less chance that your eyes will ever be affected by it. You want to see your ophthalmologist regularly, yearly at a minimum. Many times, the doctors will ask, primary care doctors will ask the patient, "Oh, did you have your eyes checked?" And they say yes, but they were actually just going and getting their glasses renewed or their contact lenses renewed. That's not the same as getting a full medical exam. So make sure either your optometrist or ophthalmologist does a dilated exam where they put drops in, they dilate your eyes, they really take a look at the retina and make sure everything's okay. Initially, most of the time when I see patients with diabetes, there's no issues at all. I take a look, I said, yeah, I don't see any change from diabetes. I let their primary care doctor know that everything looks good. And I'll say, okay, see you back in a year. If I ever see changes, we see some mild changes, that's a warning sign for us to let the patient know that, hey, I'm seeing some changes here.
He knows quite a bit.
Try to get your sugar under a little bit better control, and talk. And I let the primary care doctor know that as well. So they might do more testing on the kidneys or the heart or other things that are not as easy to see as the eyes. And we may see patients more frequently than if we see changes, every 6 months or 9 months or 4 months, just depending on what we see. But if everything looks okay, we just say come back in a year. Again, if you notice any vision changes and you have diabetes, call your ophthalmologist or optometrist right away. And if we're diagnosed with some changes, depending on what we see, we do start treatment. Again, early on, there's really no treatment besides getting your sugar under better control. But if it's more advanced disease, then we do have some treatment options. So question 6, what are cataracts? And I know this has happened, some of you may have had cataract surgery on this that are listening in right now may have had cataract surgery already. Some have been told that you have cataracts. They're not quite ready yet. But we'll talk a little bit about more what cataracts actually are. So we talk about that lens in the eye that gets flexible and gets less flexible with age. When you're young, it's nice and clear, just like lenses in your glasses. As you get older, that lens becomes cloudy, becomes yellow. Certain diseases like diabetes can cause it to become more cloudy more easily. Certain medications can make it cloudy more easily. So when the lens becomes cloudy and yellow, we start calling that a cataract. What are some of the symptoms of having cataracts? Initially, you might have some blurry, hazy vision. Things just don't seem quite as crisp as what it used to be. Colors seem much less vibrant. That's one of the biggest complaints I get. Or I really don't get the complaint before surgery. It's after a patient's had cataract surgery. And that's one of the biggest things that patients tell me afterwards is they say, wow, I didn't realize what I was missing with my TV. The colors of my TV, I thought my TV was going bad, but it was actually my eyes. Or they might say, I didn't realize the grass was so green. I had forgotten how green the grass was. So the colors seem less vibrant with cataracts. You kind of get a ghosting of images as well. And then one of the earliest signs is a glare with headlights or bright sunshine. So oncoming headlights, especially on a rainy day, you feel like you see halos around it or streaks around it. This picture is a good example of what patients with cataracts might see with oncoming headlights. Again, if you're having any of these symptoms, you should get checked because it could be something that the cataracts are starting to get ready for surgery or bothering enough. We would talk about doing surgery to help you improve the vision. So question 7, I've been told that I have cataracts, but they're not ready for surgery. Why? And a lot of times I get what a lot of patients will say is I've been told they haven't ripened yet. And we'll talk about what that ripened actually means as well. So when are cataracts ready? So almost everyone over the age of 55 or 60 has some sort of cataract. Okay, so and that's why when you, if you're at that age, you might be told by your doctor that, yeah, you have some cataracts, but they're not quite ready for surgery. Okay, it's rare for me to see somebody over the age of 55 or 60 with no cataract at all. Cataract surgery happens when two things happen. Okay, we talk about cataract surgery when two things happen. One is that, number one is when I think, as a doctor, I think it's ready for surgery. But number two, which is much more important to me, is it's affecting your everyday life, your daily activities. Okay, and so within the medical community, we call this ADLs. ADL stands for activities of daily living. Insurance companies also look at ADLs, activities of daily living. So if it's affecting your everyday life, your daily activities, that's when we start talking about doing cataract surgery. Just to give some examples, I have patients that are much older. They might be in their mid-90s. They have pretty bad cataracts. Their vision's not too good, but they tell me, you know what? I don't drive anymore. I can get around the house. I'm okay. I can do what I need to be able to do. I don't think my vision, my vision is not limiting my activities. So in that case, we don't talk about doing cataract surgery. We say, okay, you're doing okay. We're not going to, if it's not broken, we're not going to try to fix it. I had a patient about 6 months ago. He was 44 years old and very early cataracts, just mild cataracts. He had a little bit of glare issues. It wasn't that bad, but he was an airline pilot for Southwest. So he came in and he said, when I'm landing the plane, I can still, I'm fine, but I can kind of tell it's not as good as it used to be. The glare bothers me a little bit. The runway lights are a little bit harder to see. So in that case, it was, affecting not only his life, but, obviously all the passengers on the airplane as well. So we went ahead and did cataract surgery. And he said afterwards, he's like, wow, I didn't realize how much I was actually missing. So a lot of this is when it's affecting your everyday life, is when we talk about doing cataract surgery. For insurance purposes, Medicare and most other commercial insurances, they require your vision to be less than 20/40. And this is, again, best corrected vision, meaning the best glasses we can give you. Vision less than 20/40 or with glare less than 20/70 for it to be covered by insurance. There's always exceptions to this rule. I've had many patients who might be 20/30, 20/25, 20/30, but glare really bothers them, and they are truck drivers or airline pilots like this gentleman, and we can go ahead and get it approved by the insurance company.
Good. Good goal.
So what happens when my cataracts are ripe? Meaning they're ready for surgery. So only way to get rid of cataracts is with surgery as of right now. Maybe 20 years from now, we might have some medications, but right now there's no medications that can get rid of cataracts. What the cataract is, like we talked about, your natural lens is kind of cloudy and yellow. So we actually remove the entire lens and replace it with a clear artificial lens called an intraocular lens, an IOL. So you might hear us say IOL. That's the artificial lens we put into the eye. Most of the time, this artificial lens is made out of acrylic. I would say almost 95% of cataract cases, cataract surgeries get an acrylic lens. There's also some lenses made out of silicone that we might put in for certain situations, but majority of the time it's made out of acrylic. Interesting side story. The reason we found out that acrylic is a good material to make the lens out of is that fighter pilots, the fighter jets, the cockpit window is made out of acrylic. When they were, if the fighter, if there was damage to the cockpit window and some of this acrylic went into the pilot's eyes, the medical doctors realized that, hey, the body is able to actually take care of this. It's not reacting to this acrylic. And they said, well, if it's okay with this, we may as well make the intraocular lens out of acrylic. So that's how we started making the lenses out of acrylic. And this is only over the past 20 years or so, or 30 years now.
That's pretty neat.
Oh, only 30 years ago.
No, the acrylic lens.
That's what I meant.
So what to expect before surgery? So if you are, going to see your doctor and they feel like you have cataracts and you're ready for cataract surgery, there's going to be a complete dilated exam. So we dilate your eyes, we take a look, make sure there's no other medical issues going on with the eyes, no other eye issues at all. That really gets us so I can see the cataract. I know what I'm expecting on the day of surgery. I don't want to be surprised on the operating room table by seeing something that I didn't see in the office prior. We take a lot of measurements to determine what power lens to put into the eye. And we'll talk more about lenses in just a few minutes. But we'll take a lot of measurements to see what power lens to put in the eye. You would meet then with the surgical coordinator in the office, and that's when they would schedule the surgery and talk to you about the consent forms and what drops you got to take before surgery, what drops you'll take after surgery, fasting, all of that stuff will be talked about with the coordinator. On the day of surgery, most of the time we do surgeries in an outpatient surgery center or in a hospital. Around this area, it's rare to get it done in a hospital. So if you're seeing an ophthalmologist in Howard County, Anne Arundel County, Prince George's County, and Baltimore City, most of the time it's going to be done at an outpatient surgery center. You would show up there about an hour before surgery. The nurses will dilate your eyes, the eye that you're having the surgery on. Anesthesia also will give you an IV. You get a little bit of sedation through the IV and some numbing drops. You're awake during the surgery. You're in a twilight. You're not completely awake. You're not completely asleep. And the reason we do this is that after the surgery, we want you to be, fully awake within a few minutes and walking out the door. I always tell patients that during surgery, they might hear what's going on. They might hear the music being played in the operating room. You're not going to remember too much of it the next day with the medications that are given to you. But if something bothers you during surgery, and I can adjust that for you. More importantly, I can talk to you, and if I need you to look in a certain direction, turn your head a certain way, I can talk to you and you can follow my directions pretty easily. Surgery can be anywhere from 10 minutes to 25, 30 minutes long. We usually say it's about 30 minutes or so to patients. And then you're in the recovery area about 15 to 30 minutes afterwards, and you walk out the door. So overall, I tell patients you're there about 2 hours, 2 to 2.5 hours total in the surgery center. So are there different lenses to choose from? And for those of you who had cataract surgery, I'm sure the ophthalmologist that did your surgery talked about the different lenses. So a standard lens, we call that a monofocal lens. Monofocal meaning one focus. So this is a standard lens that we would put in the eye. And most of the time we correct patients for distance. So we try to choose a power lens to help them see far away, without glasses as much as we can. Reading, they'd have to still definitely wear glasses. This lens is covered by insurance, okay? So Medicare and all the commercial insurances part of cataract surgery includes this monofocal lens. This picture here is a picture of a lens, and sorry, my mouse you're not able to see my mouse pointer here, but this is a picture of an artificial lens that gets put in the eye. Now, the actual artificial lens is about 14 millimeters, so about 1.5 centimeters in length. So of course, this is enlarged quite a bit here. And the circular part you see in the middle, that's the actual lens. So that's what you're seeing through. The two little arms that you can see on the top and bottom of the lens, those are little springs basically. And what they do is they hold the lens in place. So the lens is made up of that circular part, which is what you actually see, and that's what changes, we choose the power of that part of the lens. And then the two springs kind of hold the lens in place. When we're doing cataract surgery, this lens is 14 millimeters in length. So we're obviously not making an incision 14 millimeters long. 14 millimeters is a pretty long, pretty big incision. The incisions we make are somewhere between 2 and 3 millimeters, and we do the entire surgery in that 2 to 3 millimeter incision. So the way we get this lens in is this lens is actually folded up like a burrito. And we fold it up, we stick it through that incision, put it into the right position, and then we have it open up inside the eye. So that's been a big advancement in technology in the past 25, 30 years of being able to do that with the lens. So we don't have to make a very large incision. You don't need too many stitches, things like that afterwards. The second lens that a lot of patients might get is a toric lens. This toric lens helps correct astigmatism. So if I go back to the monofocal lens here, this monofocal lens can correct your farsightedness and nearsightedness. So someone who has no astigmatism, this monofocal lens might be a good lens for them. If you have astigmatism, then really to get the best corrected vision, you would get a toric lens. This toric lens, if you see where the two little springs are, you see 3 little dots there. Those 3 dots are the axis of the astigmatism. So somebody who has astigmatism has astigmatism in a certain degree. It might be at 90 degrees, might be at 45 degrees. We measure that ahead of time. When we put this lens into the eye, we can actually rotate the lens into the correct axis so that it will help reduce the astigmatism. So again, this helps reduce, so patients who have astigmatism and farsightedness or nearsightedness, putting this lens in will really help correct their distance vision. This lens is not covered by insurance. Again, insurance companies say that this is a premium product. So they cover the monofocal lens, but you usually have to pay out of pocket for this toric lens. And then the third lens that is often used is a multifocal lens. This is like a bifocal inside your eye. So it helps you see far away and up close both, really reduces your dependence on glasses. It doesn't mean you don't need glasses at all. I do have some patients who, we put this lens in, they're great for most things, but they say, if I really sit down to read for a long time, I might put on reading glasses. Or if I am driving at night, I might put on some driving glasses. But for majority of what they do, if they go to a restaurant, they want to look at the menu, they're able to see that all okay with this multifocal lens. Not everyone's a candidate for this lens. If you are, usually the ophthalmologist will talk to you about that. Again, this is a great lens, but it's not covered by insurance. Insurance companies will cover that standard lens we talked about. Anything above that is you have to pay out of pocket for. Another question that we get asked often is, are lasers used for cataract surgery? If I was giving this talk about 8 or 9 years ago, I would have said, nope, we never use lasers at all. But in the past 7, 8 years, we started using lasers now for cataract surgery.
No.
So traditional cataract surgery, we make the incisions by hand. The surgeon opens up the front part of the cataract. An ultrasound probe is used to break up the cataract and remove it. And this is all covered by your insurance. Laser-assisted surgery, which has been around now about 7 or 8 years, the incisions are made by laser. It can actually help reduce some of the astigmatism. So if you have just a little bit of astigmatism, not too much that you need that astigmatism lens, we can actually reduce some of that astigmatism with this laser. And the laser does some of the steps of the surgery for us. It will open up the front part of the cataract and softens the cataract up. So when I go in there with my ultrasound machine to break it up, it just takes less energy, less trauma to break up the cataract. It's a great technology. Unfortunately, again, it's not covered by insurance. So there's an out-of-pocket expense for the laser-assisted surgery. In my patient population, about half my patients choose to get the laser-assisted surgery. The other half say it's a lot of money and they go the standard way. I just like to always just give all the options to all the patients and let them make the decision of what they want. So laser-assisted surgery, the advantages of the laser is that the incisions are very precise. It may improve the accuracy and consistency of what we do. Studies have shown, though, that there's really no difference in complication rates and recovery time. So again, the FDA doesn't allow us to say the laser way is better of doing surgery, but I would say the results are a little bit more reproducible, meaning if I choose a certain power lens. If I feel like you need a certain power lens, I think that we're more likely to get the what we're aiming for with the laser surgery than the standard surgery. So another question we get, I'm kind of going away from cataracts now, is why do my eyes feel tired and burn after I'm on the iPad for some time? Okay, and this is becoming more common, especially with all these Zoom calls, Zoom conferences. Over the past year, we've been probably had more screen time than you've had your entire life. So this is all from dry eyes. Okay, eyes need to be have tears to stay healthy and comfortable. Your dry eyes can occur if your eyes don't produce enough tears, or if the tears that are produced are not healthy and they evaporate too quickly. So there's two reasons you can get dry eyes. Some of the common symptoms of dry eyes is you get some stinging and burning, excessive tearing, sandy, or you feel like you have gravel in your eyes. You might get episodes of blurry vision, and then also redness is a common dry eye symptom. I'm going to talk a little bit more about a few of these. So excessive tearing, a lot of patients will be confused. They say, my eyes are tearing, watering all the time. They're not dry. And the reason this happens is that you have two different types of tear glands in your eyes. One's a small gland that's producing a little bit of tears all the time. And the other one's a much larger gland that acts like a dam. So if it senses that the eye is dry, it turns itself on, gushes tears for 15, 20 minutes, says, okay, it's moist enough, turns itself off, and then 2 or 3 hours later, the same thing might happen again. So I explain this to patients that, it's actually you're tearing more because your body's trying to produce more tears. But if we could treat the dry eyes, that will actually help some of that excessive tearing episodes get. Episodes of blurred vision is also interesting. A lot of patients will come in and see me and they say, oh, my eyes, my glasses are going bad, or my cataracts are worse because I keep getting blurry vision. One of the big things is we call this fluctuating vision. So if they say, at sometimes my vision's great and other times it gets blurry, that's usually more from dryness. If it's actually something in the eye, like cataracts, or if it's an issue with your glasses, your vision will be blurry all the time. You're not going to have some hours where it's more blurry than others. But when your eyes do get dry, you can kind of feel like you're looking through film at times, and you might blink a lot more to clear your vision up. That's all part of dry eyes. Blinking is like a windshield wiper. It just helps clean the surface off. So what are some of the causes of dry eyes? Unfortunately, aging is the number 1, 2, and 3 cause. As you get older, everything dries out, including your eyes. There are certain medications like diuretics. If you're on medicines for high blood pressure, that can cause dry eyes. Antidepressants can also cause dry eyes. Another big thing right now is digital device use, meaning iPads, cell phones, computer screens, laptops. Anytime you're staring at anything, your eyes tend to dry out more than they would if you were, relaxed and just talking to a friend or something. Contact lenses can dry the eyes out more. Certain diseases can cause more dry eyes as well. And a dry environment is a really big cause of dry eyes as well. Dry environment, wintertime is always worse. We can't all be like Michael and go down to Florida for winter. So we're stuck in Maryland, and Maryland is extremely dry in the wintertime. So I see a lot more dry eyes in December, January, February than I do in June or July or August. Wintertime, your heat's on, the air is dry, the skin dries out, everything tends to dry out. So some of the tips for dry eyes in cold weather, and I know, fortunately we're starting to get out of the winter time now, and hopefully the weather will improve over the next few weeks. But I really recommend, if you do have dry eyes, to get a humidifier for your, especially for your bedroom at night. That helps a lot. Many homes have central humidifiers, and they do work well, but they don't work quite as well as one of those little room, little units you can put in the room. And, I tell patients, I say, move that around. So if you're in your office all day in front of the computer, take that thing to your office and let the humidity increase in the office. It will help a lot with the dry eyes. Drinking lots of fluids help. If your eyes are really dry, of course, see the doctor. We have treatment options to help you get the dry eyes to be better. Diverting heat from your face. This is a big thing. So if you are in the car and you have the vents blowing right on your face, that tends to dry the eyes out a lot. So if you suffer from dry eyes, or you say, after an hour or two of driving, my eyes really bother me, look and see where your vents are pointing. Point them away from you. Either point them down to feet or up, and that will just not having that air blowing on you all for while you're driving will help a lot. So some of the treatment options for dry eyes. The first thing we use are artificial tears. Of course, we talk about the environmental changes, and so less screen time, less get the humidifier, things like that. Artificial tears, these are over-the-counter drops. What I have here on the left side are a few different brands. There are common brands that we find at any drugstore, any pharmacy, grocery store, Costco, Walmart. They all have these. To me, it really doesn't matter which one you get. To me, they're all about the same. I do have patients who will tell me that they prefer one brand over another. So if you could try a few different brands, if you find that one seems like it works better or you feel better, then keep getting that same brand. The one thing I say not to get is anything that says gets the red out. So you should never get the drops that say gets the redness relief, like Visine or Clear Eyes. They don't really help with dry eyes at all. And if anything, they can actually worsen dry eyes. The only time I say it's okay to use these red eye drops like Clear Eyes or Visine, if your eyes are really red and you have a job interview or a family photo or a wedding, go to some big social event, you want your eyes white, go ahead and put a drop in, but not for an everyday use. If the artificial tears are not enough, some other treatment options we have are to put a plug in the drainage system of the eye. So in your lower eyelid, you actually have a drain that drains your tears into your nose. So when patients have dry eyes and the artificial tears aren't enough, we can actually plug that drain. Just like if I plug the drain in the sink or your bathtub, the water level increases. If we plug the drain in your eyelid, your tear level increases. And this is done right in the office. Just takes a minute per eye to put them in. It's a very painless procedure. So we do this quite often to help patients with dry eyes. This is also covered by Medicare, and all commercial insurances cover this treatment. So it's a really good option as well. And then finally, another treatment option, if that's all not enough, is then we start talking about doing prescription eye drops. You may have seen commercials on TV for medications like Restasis or Xiidra or a new one called Cequa. These are all prescription eye drops that create more tears, more healthy tears. Really helps, with the dry eyes. And again, I treat dry eyes as a stepwise approach. I don't throw everything at you if you don't need it. So if somebody comes to me and they're not doing anything at all, I say, okay, go use artificial tears, get the humidifier, let's do this, a few other treatment, environmental changes, come back in a month. If it's not better, we'll be more aggressive. So another question I get is, why do I see gnats or cobwebs or specks or lines in my vision? And what these are, we call these floaters. Many patients have these floaters. It's tiny little clumps of gel or cells inside the vitreous. The vitreous is the jelly of the eye, and it starts filling up your eye. And what you're actually seeing are the shadows that these little clumps of gel cast on your retina. And that's why you tend to see these more when there's brighter light outside. You don't see them in a dark room because there's nothing there to cast a shadow. Most of the time, these floaters are not a problem. It's kind of a natural process. As you age, more and more likely you're going to get floaters. Completely natural process. However, floaters can also be a sign of a serious problem, mainly a retinal tear or a detachment of the retina. So if you do get floaters, you should definitely get checked, make sure that the retina is okay. Some of the warning signs, if you notice a lot of new floaters, you get flashes like lightning bolts going off in your eyes, you see a shadow or a curtain coming across your vision. These are all kind of warning signs that, go get the retina checked, make sure everything's okay. Most of the time, no treatment is indicated for floaters. Usually symptoms improve with time. What happens is your brain learns to ignore these. So many of you who may have had floaters at some point in your life, no longer see them there. And when I have some patients where I'll look for their annual exam, and I ask them like, oh, do you still see floaters? And they say, oh, no, I haven't seen them in years, but I still see them. So they're still there, but your brain is a smart thing and it starts to ignore them. Even then, patients 10 years later might tell me, certain lighting conditions, if I look against a white background, if it's really bright and sunny outside, or if I really try to look for the floaters, I'll see them there. But most of the time, it's fine. It doesn't bother me at all. So I think that's kind of the common questions that I had thought of that I get asked a lot. I hope that was helpful to everyone. And of course, opening it up for any other questions at all. I'm happy to take any questions and try to answer the best I can about anything. And again, here's my information. So if you have a personal question, of course, call me. I'm happy to talk to you afterwards.